Assalamu alaikum and good day to everyone. Today, I'm going to give a lecture on asthma in children. Learning outcomes. At the end of this lecture on asthma in children, the students should know definition, pathophysiology, symptoms and signs, investigations, assessment of control and severity, treatment of acute exacerbation, long-term management of asthma in children. First of all, we need to know, what is asthma? It is a chronic inflammatory disorder of the airways, which is characterized by variable airflow obstruction that is reversible with treatment or spontaneously. In this condition, there is increase in airway responsiveness which causes asthma symptoms including wheezing, coughing, chest tightness, and breathlessness, particularly at night or early in the morning. This slide illustrates the pathophysiology of asthma. It comprises immediate and delayed inflammatory responses. During the early phase, allergen exposure leads to mast cell degranulation. That leads release of mediators such as histamine and leukotrienes. These lead to mucus hypersecretion, vasodilation, edema, and bronchoconstriction. During the late phase, chronic inflammation may result in smooth muscle hyperplasia, bronchial hyperresponsiveness and increased collagen deposition beneath the basement membrane, leading to bronchoconstriction. So how do we make diagnosis of asthma? First and foremost, the diagnosis is made based on history, and then physical examination. Investigation is just supportive and not crucial in establishing the diagnosis of asthma in children. So please remember that asthma is a clinical diagnosis. Now we will go through the history that needs to be taken when evaluating a patient with symptoms suggestive of asthma. We need to ask the following questions. What are the patient's current symptoms? What is the pattern of the symptoms? Is there any history of exacerbation? Is there any relevant past medical history? And are there any significant family and social histories? In the next few slides, I will go through the details of each of these points. Regarding the current symptoms that patient has, we need to ask whether he or she has symptoms of asthma, which include cough, chest tightness, wheezing, and shortness of breath. If the patient has symptoms of asthma as mentioned earlier, we need to find out whether these symptoms are recurrent, especially in the morning, at night, or during exercise. The frequency of the symptoms should also be inquired. For example, how many times does the patient have the symptoms in a week? In terms of asthma exacerbation, we need to ask about its frequency, severity and treatment received. This include inhaler usage, nebulizations, and admissions either to the ward or intensive care unit. If the patient has history of admission to the intensive care unit due to asthma exacerbation, don't forget to ask specifically whether he or she has history of intubation. We should also inquire about the factors that trigger the exacerbations. Common triggering factors in asthma patients include cold drinks or environment, upper respiratory tract infections, dust, standard smoke as well as certain food. In the past medical history, we need to find out whether the child has history of other atopic diseases. These include allergic rhinitis, eczema, allergic conjunctivitis, or food allergy. Similarly, we need to inquire regarding family history of ASTHMA, which includes asthma, allergic rhinitis, eczema, allergic conjunctivitis or food allergy. It is also important to ask regarding the frequency that the patient is absent from school due to asthma exacerbations. Lastly, we need to ask about the presence of factors that may worsen asthma symptoms, such as smoking, pets, and carpets in the house. When examining the patient with suspected asthma, we need to look for signs of ASTHMA. These include eczema, allergic rhinitis, and ocular shiners. Presence of aerosol sulci indicates that the patient has chronic poorly controlled asthma. It is also important to check for signs of acute exacerbation in the patient. These include respiratory distress such as tachypnea, nasal flaring, and recession, as well as presence of bronchi on auscultation. Please bear in mind that normal physical examination does not rule out the diagnosis of asthma. These are pictures of eczema and its common sites. It is erythematous itchy rash with scaling and excoriations that are typically found on the face in infants and overflexural area in older children. The signs which indicate the presence of allergic rhinitis include allergic salute, which is rubbing of tip of the nose with palm of the hand. Nasal crease, which is transverse crease over lower part of nasal bridge due to repeated action of allergic salute. And hypertrophic nasal turbinate, which can be visualized using otoscope. Ocular shiners are dark circular circles around the eyes. It is a sign of allergic conjunctivitis. Aerosol sulci is horizontal groove or depression over anterolateral aspect of lower part of chest, which corresponds to the costal insertion of the diaphragm. There are several investigations that can be done to support the diagnosis of asthma. These include peak flow, spirometry, and chest X-ray. Peak flow can be used in children more than 5 years old. It is maximum flow during maximal force of expiration following full inspiration. The results vary with age, gender, height and population. Reversibility is defined as improvement in peak flow of more than 15% after administration of bronchodilators. Spirometry is another supportive investigations for making diagnosis of asthma in older children. It measures force expiratory volume in 1 second, force vital capacity and reversibility. Patients with asthma typically have reduced FEV1, which indicates the presence of airway obstruction. Chest X-ray is not routinely indicated in establishing the diagnosis of asthma. The main indication to do chest X-ray is if we suspect alternative diagnosis such as parenchymal lung disease, pneumonia, congenital lung anomalies, or a foreign body. In patients with acute asthma who respond poorly to therapy, chest radiograph is useful in detecting complications such as pneumothorax. The main finding in chest X-ray for asthma itself is hyperinflated lung fields. At the initial diagnosis, we need to categorize the patient into intermittent or persistent asthma. Patients are regarded to have intermittent asthma if they have daytime symptoms less than once a week, nocturnal symptoms not more than twice a month, no exercise-induced symptoms, and brief exacerbations not affecting sleep and activity. Those who do not fulfill these are considered to have persistent asthma. Next, I'm going to talk on principles of management on asthma. It involves asthma education, avoidance of triggering factors such as food, cold drinks, pets, carpet, and smoking, pharmacotherapy for long-term asthma control, management of acute asthma exacerbation, as well as management of comorbidities such as eczema, allergic rhinitis and allergic conjunctivitis. For the next few slides, I'm going to explain on the pharmacotherapy for long-term asthma control and management of acute asthma exacerbation. Now I will explain the long-term pharmacotherapy in asthma. Step 1. Patients with intermittent asthma should be started on short-acting beta-2 agonists such as salbutamol, which is to be given whenever needed. Step 2. Patients with persistent symptoms of asthma need to be commenced on regular preventer therapy. The first choice is low-dose inhaled corticosteroids such as budesonide, beclomethasone or fluticasone. Leukotriene antagonist such as montelukast is an alternative. If the asthma is not controlled, we need to check the compliance inhaler technique and emphasize on the avoidance of triggering factors before stepping up the medications. Step 3. The next step of management is to increase the inhaled corticosteroid to moderate dose. Step 4. If the asthma is still not controlled, the next step is to add long-acting beta-2 agonists such as salmeterol. Step 5. If the asthma is still not controlled, the patient can be managed on combination of moderate dose inhaled corticosteroid with long-acting beta-2 agonist and leukotriene antagonist. The alternative is to commence the patient on high-dose inhaled corticosteroid with long-acting beta-2 agonist. Children generally are not able to use metered dose inhaler directly, so they need to use special inhaler devices for drug administration. Children less than 8 years old should use metered dose inhaler administered via air spacer with mask. Older children may use breath-actuated devices such as EasyHaler, TurboHaler or DiscHaler. Next I will discuss the acute exacerbation of asthma. It is an episode of progressive increase in shortness of breath, cough, wheezing, and chest tightness which is usually associated with triggering factors such as upper respiratory tract infections, taking cold drinks or certain food as well as exposure to cold environment, dust or smoke. So what do we need to do in acute exacerbation of asthma? First we need to confirm the diagnosis. Then we need to assess the severity. Identify the precipitating factor. Look for presence of complications. And assess the long-term asthma control. Please bear in mind that not everyone who presents with acute respiratory distress and bronchitis has asthma. The differential diagnoses include acute bronchiolitis, pneumonia, foreign body aspiration, anterior mediastinal compression, acute pulmonary edema, and anaphylactic reaction. This table shows the parameters used in the assessment of severity of patients with acute asthma. The severity can be divided into mild, moderate, severe and life-threatening. Patients with mild acute asthma can't talk in sentences, are alert, have no recession and bronchi is heard on auscultation. Those with moderate ones can't talk in phrases. They may be agitated. Recession and bronchi are both present. Patients with severe acute asthma can't talk only in words. They are usually agitated, have moderate to severe recession and generalized bronchi. Those with 2 are too breathless to speak, have drowsiness, paradoxical breathing or silent chest are considered to have life-threatening acute asthma. There are several other parameters that are used in the assessment of acute asthma. These include respiratory rate, oxygen saturation on air, pulse rate and peak expiratory flow rate. Patients with mild acute asthma are not or mildly tachypneic. They are not tachycardic with oxygen saturation on air of more than 95% and peak expiratory flow rate more than 80% predicted. Those with moderate acute asthma are tachypneic and tachycardic with oxygen saturation on air of 92 to 95% and peak expiratory flow rate between 60 to 80% predicted. The patients with severe acute asthma are very tachypneic and tachycardic with oxygen saturation on air less than 92% and peak expiratory flow rate less than 60% predicted. Those with life-threatening acute asthma have poor respiratory effort, bradycardia, cyanosis and are unable to perform peak expiratory flow. This table shows the upper limit respiratory rate for age. For infants less than 2 months old, the respiratory rate should be less than 60 breaths per minute. For those between 2 and 12 months old, it should be less than 50 breaths per minute. For children between 1 and 5 years old, it should be less than 40 breaths per minute. And for those between 6 and 8 years old, it should be less than 30 breaths per minute. The treatment of patients with acute asthma involves the use of oxygen, short-acting beta-2 agonist, ipratropium bromide, steroid, and magnesium sulfate. Oxygen is important as initial therapy in acute asthmatic attack. The mode of action is to relieve hypoxia. It should be given to patients who have moderate to severe respiratory distress or those who have oxygen saturation less than 95%. It can be administered via nasal prong or face mask. Short-acting beta-2 agonist is the first-line treatment in acute asthma. Its mode of action is as bronchodilator by acting on the smooth muscle. The most important short-acting beta-2 agonist is salbutamol, which is given via metered dose inhaler with spacer or nebulization. Subcutaneous terbutaline or intravenous salbutamol are used for severe or life-threatening acute asthmatic attack. Ipratropium bromide acts as bronchodilator due to its anticholinergic action. It is given via metered dose inhaler with spacer or via nebulization. It is used as an add-on therapy in moderate to severe exacerbations of asthma. The mode of action of systemic steroid is as anti-inflammatory. It is indicated for moderate and severe cases. It is given as intravenous hydrocortisone or oral prednisolone for 3 to 5 days. Intravenous magnesium sulfate acts as a bronchodilator. It is used as an add-on therapy in severe to life-threatening acute asthma. Now I will explain the algorithm in the management of acute severe asthma. First and foremost, the child should be commenced on oxygen. After that, inhaled salbutamol and ipratropium bromide should be administered. These may then be repeated. Intravenous hydrocortisone or oral prednisolone are also indicated at the initial stage. Subcutaneous terbutaline should be given if the patient is not improving with the above therapy. Next line of treatment is salbutamol, which is given via continuous intravenous infusion. If the patient is still not improving or continues to have severe respiratory distress, intravenous magnesium sulfate should be considered. Finally, assisted ventilation is indicated if the patient is still not improving on the above therapies. In summary, asthma is a clinical diagnosis. History taking is very important in establishing the diagnosis of asthma. Normal physical examination does not rule out the diagnosis. The severity and control of asthma need to be addressed as part of the assessment.